Hello, everyone, and welcome to Final Fridays with the John Ritter Foundation. We're very happy to have you all here with us today. Just some quick reminders before we get started. You can use the chat to ask questions. Those are visible to everyone, including the staff, so we may be answering you privately if a specific question comes up. We are going to have a handful of polls that Dr. Prakash will go through. So if you are willing, please complete all of those, but he'll go through them in the future. This is being recorded, as they always are, and it will be available for viewing on the YouTube channel probably later today, but early next week at the latest, as are the past sessions if you wish to review those or share those with other loved ones. And we're going to be answering questions at the end. So I have the ones that you've sent in ahead of time, and I've shared those already with Dr. Prakash. And then finally, just be kind to each other in the chat. As always, we're here as a supportive community who's trying to lift each other up. So before we get started with Dr. Prakash's presentation, which I know you all are very excited, I have a quick video to show you all from a dissection survivor and someone who has participated in Dr. Prakash's research, Carmen David, who I think a lot of you probably know because she's been a tireless advocate for dissection survivors, particularly those who dissected during pregnancy. So I'm going to, hopefully, if it all works well, play that real quick. And then when we're done with that, we'll come back and we'll get started answering some questions. And it's going to be a very fun and interactive session. So I see a whole bunch of people trickling in here. So we will get started and cover as much as we can today.
Hi, my name is Carmen David. I am from Dallas-Fort Worth, Texas. I just wanted to share a little bit about my story with you and my journey back to exercise after my dissection. So in 2015, I was 33 years old, and 22 hours after I delivered my second daughter, I had an aortic dissection. I do not have any family history of this and was always a very active and healthy person, and so this event took a huge toll on my life. With all the medications that I was given afterwards, I was very sluggish, had no energy, plus the limitations that the doctors were advising me of. I just thought, oh my gosh, I'm not going to be able to do anything. And then, of course, just the fear, it really made me lose who I was. I fell into a deep depression and really didn't do anything active-wise for 2 years just because I was very scared. So when I finally hit rock bottom mentally, I just thought, something has to change. This is not living. And that's when my return to exercise journey began. And it was a slow process. I, have little ones and a family that I really want to be around for. So I was trying to be very cautious about what I was doing, making sure that I knew the specifics of what I could do. And so I was very, I talked to my doctor a lot about those things and asked him, what can I do to get started? And then I found a trainer and I used that guidance from my doctor and advised my trainer, and he could modify anything for me. And then just really pushed myself to get moving again, which was hard because I was again, the medications to make you not really want to do a whole lot. Your blood pressure is supposed to be as low as functionally possible. It really makes it hard for you to want to get up to do anything or feel like it. But I felt like I really pushed myself because I needed to get moving for myself physically and mentally. Once I, started moving, then I felt like I could lose some of that weight and just really get out of the funk that I was in, because again, the anxiety and fear had robbed me for 2 years of any kind of initiative and just happiness of wanting to do anything, So once I started, I feel like it really gave me back my confidence. I felt like I was okay when I was doing my exercises, and then I started to learn how my body was feeling, and just kind of the confidence in knowing that I was going to be okay. Going to my follow-up visits and my yearly CT scans were showing stable and no rapid increase growth in things, and so that helped me to confirm that everything was going to be okay and that the exercises that I was doing were fine. It also just helped me to not have fear at the forefront anymore, because then with that confidence, the fear just started to slowly dissipate. Of course, it's never going to go away, but it just wasn't at the forefront of my mind anymore. And it just really helped me to clear my head and enjoy my life, and I feel like I was able to get out of that rut. And so a lot of times I've been trying to help other patients and just really encourage others to get moving in whatever capacity that might be for them. For me, it started with walking and then started to jog, and then it was running, and then I hike now with my kids a lot and stuff. And so there's a number of different ways to be active. So I just always encourage anybody, whatever the capacity of movement is for them, just do a little bit more than you're used to. And these small goals will turn into huge leaps. And like my story, you may be able to reach goals that you never thought you'd be able to reach post a dissection. And then you're just thrilled when you do. So I believe that taking care of your mental health is a huge aspect of post dissection or just diagnosis of an aneurysm. It's crucial to continue truly living your life, and from all the exercise and a lot of therapy. I will say don't put therapy on the back burner either, but both of those together really helped me to get back to myself, and I just wish I would have done it sooner. So if there's anything that I can do to encourage others, that's probably the big thing, is just to get moving. And that's where I think that Dr. Prakash and his exercise study is fantastic to give us a better understanding with scientifically based evidence, on what is okay and not okay for us to do. And so I'm a huge promoter of such research. So I hope that others can join me in that. I had a great time going down there to meet Dr. Prakash and be a part of the study. So yeah, if I can encourage anybody else, just get moving. You can do it. I promise.
So just to give a short introduction to our speaker today, Dr. Prakash is an associate professor of cardiology. He is an expert in genetic aortic disease. He is an expert in bicuspid valve, Turner syndrome, imaging, blood pressure management, genetic aortic disease. I might be missing one because I feel like you cover so many different fields, but most people here probably know you already, so I will stop with the introduction there. But safe to say, he is someone we're very lucky to have share his knowledge with us today. So I'll let him go. I think Meredith Ford, who is our CEO, is going to be putting up some polls for us, and he's going to walk us through them.
Thank you so much, Ellen, and thanks to everyone at the JRF for organizing this and giving me the opportunity to share some time with you today. I'm really amazed at the number of attendees. I think the interest is very high. Hopefully we can address some of your questions and concerns. And we'll get started with the presentation here. Can you see my screen?
I can see your screen.
Perfect. All right, everyone. Thanks again for chipping in with your answers to the poll. I'm going to present where we are with our studies on exercise and some background first, and then a few results, and then at the end, as I mentioned, we will answer your questions that you all have sent in, and we might have some time for some Q&A in the live chat. I guess we'll see how it goes. All right. So here are some issues that you are all probably very familiar with. For people who are living with aneurysms or dissections, there's a great deal of uncertainty about what limitations are right for each person, what are the potential consequences of exercise, and even what are the consequences of restricting physical activities after your diagnosis. We know that blood pressure is the #1 risk factor for growth of aneurysms, and certainly blood pressure can increase during exercise. Can we use clinical observations to identify rational limits for exertion is really the basis for my research, and I'll share some of those insights with you. And finally, how can we restore confidence to engage in physical activities? Physical activities, exertion, exercise are an important defining part of our lives, and it is not right to restrict them completely, but is there some balance that we can restore to people with these diagnoses? So this slide is one of many that illustrates the effect of exercise on lifespan. And I like it because it's just so illustrative in terms of the dose response curve. So dose response is the idea that if something has an effect that is real, you can tell whether it's real by measuring whether the quantity of it affects outcomes. In this case, does the quantity of exercise that you engage in on a weekly basis affect your mortality? The answer is yes. There is a dose-dependent increase in longevity based on the number of minutes of exercise you get per week. So this was a study of more than 600,000 adults ages 21 to 98, mean age of 62, and they simply filled out a survey about their self-reported moderate or vigorous physical activity, anything above mild, during the course of the week. And they were followed for about 15 years. And so what you can see is that beginning with as little as a couple hours per week of moderate exercise, you see a strong mortality reduction of 30%. And that this plateaus about 1 hour per day at around 39% and remains durable for decades afterwards. So what this means is that exercise as a drug is more effective than the most effective drugs we have for aortic disease in terms of longevity, preventing mortality, and in fact, there are other benefits which I'll talk about, but just in the magnitude of that effect in individuals is pretty astounding to me. And I keep referring to this whenever I think about how important it is to get more people moving. So if we think that living an active life is therefore important because it is a powerful way to reduce mortality, how do we get, or how can we define some principles to live that active life if you have aortic disease? The first is to know yourself. Lifelong follow-up with regular surveillance is really important so you understand where you stand in terms of your aortic disease. Knowing the status of your disease before you even begin to exercise is, of course, very important. And then taking preventative measures and monitoring how those affect your aorta over time is also important. 2 would be know how your body responds to exertion. We're all slightly different in the way we exercise and the way our body responds to exercise. So you need to understand how different types of exercise affect your blood pressure and understand your specific response to different types of exercise. It can depend upon things like the way you breathe during exercise, how fit you are, how many different types of exercise you pursue, and whether or not you pursue exercise to the point of exhaustion or not. And you can adapt to these changes over time and become more proficient at exercise. Like with anything else, if you practice, you will become better at it, and therefore your body will be able to tolerate more vigorous types of exercise over time. So the answer always changes, just like your aorta always changes. You have to keep asking yourself that question. So one of the first things that comes up in anyone with aortic disease is how likely is physical exertion to cause a dissection? The most important thing to recognize is that dissections that happen during exercise are very rare, fortunately, even in people who are considered to be at high risk. Now, interviews with dissection survivors also found that most people who had dissections while they were exercising were not aware of their diagnosis, or they were not taking medications and had uncontrolled hypertension. So we know that being on prophylactic medical therapies like antihypertensives or your beta blockers controlling your blood pressure will certainly lower your risk. And that should be undertaken before you even start an exercise program. So again, the importance of lifelong follow-up is critical here because your risk factors and disease status will change over time. Therefore, your risk with regards to specific exercises will also change. And so the answer that was right for you 5 years ago will not be necessarily right for you now. All children and adults with thoracic aortic diseases require lifelong screening. That includes things like an annual checkup with your primary care physician to make sure that your general health is good and you are able to exercise. Annual blood pressure checks at least, and medication adjustments. For people with aortic disease, of course, that can be more frequent. In fact, continuous monitoring of blood pressure is recommended. Detailed imaging of your blood vessels by a cardiologist or other aortic disease specialist, and we typically use CT scans or MRI scans. And these can be from every 6 months to 3 years, depending on your disease status and where your disease is located, which blood vessels. And finally, recognize and modify your controllable risk factors. Obviously, we talk a lot about things like smoking, but things like diet, having a salty diet or having a high-fat diet can also affect your body's response to exercise by affecting your body metabolism. So those are also important if you're starting an exercise program. So, and the know yourself is really important because no two people with aortic disease are the same. No two people with Marfan syndrome who have an aortic aneurysm are the same. Every one of us has specific risk factors and life experiences that we bring to exercise, and that affects our specific risk. An example would be how well your hypertension is controlled. Do you smoke? What is your specific gene mutation? Have you had previous aortic surgery? If so, which part of your aorta may be at risk? And whether you have been pregnant or not, or had complications with pregnancy. All of these things can increase or modify your aortic risk. So therefore, in consultation with your aortic specialist, it's really important to go through your individual risk factors and make sure that you understand them and that you are able to control any that you can control. During exercise, the pulse pounding that you feel is actually the distension of blood vessels. And this is what gives rise to people's anxiety about exercise. The idea is that with the pressure, that if the blood pressure goes up while you're exercising, the stress on the aorta also goes up. And this can increase things like the rate of expansion of aneurysms or put you at risk for an aortic dissection. So we know that there are different components of this that put you at risk. The structure of the aortic wall, for instance, which is often genetically determined, can be thinner than normal. You could have high blood pressure, which increases the arterial pressure. And you can also have a pre-existing aneurysm, which thins out the aortic wall. So all of these things, including the imaging results that your doctor gets and the type of medication you're on, which can affect your blood pressure response to exercise, can have a real impact on your ability to tolerate exercise and your aorta's response to it over time. So before starting exercise, as we mentioned, in addition to a detailed assessment by your physician, it's important to control your blood pressure. The current guidelines recommend an ideal blood pressure of 120/70, no more than 130/80 for your systolic and diastolic readings. And these are important not only to measure in the office, but also at home, because home blood pressure readings can vary quite markedly from office blood pressures and may even underestimate the severity of pressure. The office blood pressures may even be too low. So it's important to know where you stand with that. We recommend beta blockers to most people with aortic aneurysms or dissections, but there are also other medications such as angiotensin receptor blockers that can be effective to control hypertension, and those should be titrated to the right blood pressure before you start an exercise program. So these two types of medicines, the beta blockers and angiotensin receptor blockers, have markedly different mechanisms of action. One affects the heart more and one affects the blood vessels more, but the bottom line is that both of them have clinical evidence for reducing the growth rate of aneurysms and the risk of dissections over time. And most people who had dissections while exercising were not taking adequate doses of blood pressure medication as measured by their blood pressure at the time of the dissection or their medication list. So how safe is exercise for patients who have aortic disease? There actually is a growing body of evidence that exercise can be quite safe in a controlled setting. By controlled setting, we mean that someone has evaluated you before you exercise and you're being regularly followed by a physician. It doesn't necessarily mean that you have to exercise in the presence of an aortic specialist, although that has also been tested. The safety of moderate exercise was validated first for patients who had abdominal aortic aneurysms, and it even has been shown to decrease the rate of some abdominal aortic aneurysm enlargement over time, although this has not been validated in larger studies. There have been 3 different international studies about cardiac rehabilitation after aortic surgery, which many of you may have already experienced. It's very important to do cardiac rehabilitation because the heart and blood vessels are profoundly affected by aortic surgery and take a long time to recover. These have not only been shown to speed recovery, but they're quite safe and effective in terms of increasing stamina, improving overall quality of life, and and in many cases, lowering blood pressure in people with aortic disease. Finally, most recently, in mice with Marfan syndrome gene mutations, moderate exercise can actually slow down the rate of aortic growth. And we think that the same thing could be true for humans, although this needs to be tested in long-term clinical studies. The bottom line is that the intensity, acuity, and dynamic component of exertion can differentiate beneficial exercise from harmful stress that triggers dissections. This includes, exercising in a controlled setting with a prescription that tells you what types of activities may be safe and a threshold to determine how to avoid harmful exertion that can actually raise your blood pressure and increase your risk. So the risk of exercise is associated with the type of exercise as well. We know that in patients who are exercising aerobically, the systolic pressure tends to increase gradually, like that red line, and plateaus after the blood vessels are fully engaged and delivering oxygen to the muscles. Eventually, at the end of aerobic exercises, blood pressure even declines, and this decrease has been measurable up to 24 hours after completing a session of moderate aerobic exercise. So the benefits appear to be much longer lasting than the exercise itself. In contrast, isometric or isotonic exercises are defined as when you're contracting muscles but not moving translationally in space like you are in aerobic exercise. An example of this that most people would recognize is weightlifting, but you can also do body weight exercises like the planks we mentioned earlier. In those settings, blood pressure can increase suddenly and relatively unpredictably because it depends on the way you breathe during the exercise, trying to avoid that Valsalva maneuver or contraction of abdominal muscles, which can drive up pressure inside the chest and therefore pressure on the aorta. And depending on your level of training, these fluctuations of blood pressure can be quite dramatic, sometimes reaching up to 250 to 300 millimeters of mercury in people who lift heavy weights. Now, this does appear to pose some risk in that there have been case reports of aortic dissection in people who have lifted weights, which are widely cited. However, I have to emphasize that these are, again, quite rare. And even in those cases, these were not individuals who were on any sort of prophylactic therapy. So we don't really know whether that could have prevented the dissections, but it's reasonable to assume that they weren't addressing all of the risk factors that I mentioned before. So the difference between isometric and isotonic exercises and aerobic exercises is summarized on this slide. The main difference is predictability. Isometric and isotonic exercises cause sudden and short-lived increases in pressure with each repetition of lifting. And these cannot be readily measured because they're so transient. It's very difficult for us to actually get accurate measurements. But we do know from some early studies, as I mentioned, that these can be quite dramatic. And it's the change in the blood pressure that's so dramatic, so quickly, so suddenly, that actually appears to exert a shearing force on the blood vessels. And this is what is believed to cause the danger. That is why there's so widespread limitations on the amount of weight that you can lift if you have been diagnosed with aortic disease. In contrast, aerobic exercise feature a gradual and predictable change in systolic pressure, leading to a plateau and eventual long-term decline that lasts well after exercise stops. For this reason, aerobic exercise is generally well tolerated, and we can actually test whether someone is likely to become hypertensive during specific aerobic exercises because it's easy to measure changes in pressure during those conditions. Therefore, an exercise prescription is typically given for people who are doing aerobic exercise. So the risk of exercise is also associated with exercise intensity. This is a commonly cited table that was created for something called the American Time Use Survey, which was basically a large survey of people's weekly activities. And it's categorized based upon the static or isometric or dynamic and aerobic components of the exercise. So you can see at the very bottom, the relatively low impact sports. And then as you get to the top right, you have very high impact sports with a lot of stress and strain, a lot of translational motion of joints, and heavy lifting. Things like rowing, for instance, would typically be considered a quite vigorous form of exertion, whereas something like golf or shooting would be a less vigorous form of exertion. So it's both the intensity and the isometric and dynamic components that really are separating out which exercises are considered to be riskier for people with blood vessel disease. Now, obviously, in most cases, we tend to restrict individuals with aneurysms or dissections to the four squares that are outlined in blue. And I wanted to bring your attention to some things that I added to the table because they weren't in the original version. But one that's commonly asked about is sex, and sex is safe. It's generally considered to be a low impact activity with minimal static or dynamic components. And so we do not restrict sexual activity from this category. Now, walking and hiking is also in here, and you can see that several sports are also in here. Now, some of these depend upon the level of contact, and I would not necessarily agree with putting rugby in the intermediate term because I think many people would agree that contact sports are probably risky for people with aortic disease, and we are not ready yet to apply that more widely. So the other thing that we know from studies of healthy people is that how high your blood pressure gets during exercise can also predict your long-term cardiovascular outcomes. This is a study of people who are exercised on a treadmill and had their blood pressure measured every minute on the treadmill. Those that achieved blood pressure larger than 160 millimeters of mercury during the second stage of exercise, which is moderate intensity, not strenuous, were followed then for 20 years and compared with those who did not achieve a higher blood pressure during exercise. What we found is that the people who had a blood pressure of 160 or greater during aerobic exercise had a significantly higher rate of cardiovascular death in the subsequent 20 years. And so this has kind of become the standard for looking at or stratifying people based on their aerobic response. Again, I would say that some of this has to do with being normotensive or having normal blood pressure at baseline. If you have high blood pressure at baseline, it should be controlled before you start exercise. So in general, these were healthy people who had normal blood pressures at baseline, and whether or not they achieved 160 during the aerobic phase of the exercise was used as a determinant in the study. We don't have data for people with aortic or vascular disease and for this specific question, but it is something that we are interested in looking at in our study. So this also indicates that it's not really the absolute blood pressure, but it can be the rate of rise of blood pressure during exercise, which determines your risk. So in this case, we're looking at an individual on the top who's on a treadmill, and we gradually increase the speed of the treadmill so that they go from resting to moderate exercise over a period of about 10 minutes. And we measure the blood pressure at each stage. You can see at the top, the systolic blood pressure at rest starts out at 120, but this individual rapidly becomes hypertensive during exercise and reaches a peak systolic pressure of 210 millimeters of mercury, very high, and that persists after he stops exercising. So it's not only the amount of blood pressure increase, it's the rate and also the prolonged hypertension after exercise that appears to mark people who are at higher risk to have problems with blood pressure and therefore, in terms of aortic disease, a higher risk of progression. We also measure different components of hypertension, and one of them is the stiffness of the blood vessels. This is a machine that measures blood vessel stiffness by adding in pressure waves from different parts of the aorta, and it can give us what we call a central aortic blood pressure, which in many ways is more accurate than measuring the blood pressure in the arm alone, because it accounts for the actual blood pressure that the aorta sees and not the blood pressure that we kind of measure on the periphery. So we look at these three important considerations for blood pressure during exercise: the maximum blood pressure that would be experienced by the aorta, how quickly blood pressure rises, and how long your pressure stays at or near the maximum value. So prolonged exposure to pressures over 140 millimeters is considered a risk factor for new dissections or progressive growth of aneurysms. Therefore, minimizing the time that your pressure peaks is one goal of a responsible exercise program. So here's some practical steps during exercise that can limit the amount of hypertension, exertional hypertension that you may experience. Again, everyone is different, and that's why we encourage observation, to really develop individualized exercise goals. One general recommendation would be to limit the repetitions that you have, whether they're aerobic runs or lifting, to avoid fatiguing, because we know that when you become fatigued, your blood pressure can shoot up. You want to avoid straining of your chest and abdomen, because we know that based on the weightlifting data that I showed you, that can skyrocket blood pressure. And that can certainly cause problems with with rapid increases in blood pressure, which we said are the ones that appear to be the most dangerous as triggers for dissection. The idea would be to pursue moderate, not strenuous exercises with a primarily aerobic focus because of the gradual increase in blood pressure in those conditions. And then instead of interval training, focus on a steady, moderate tempo. In that scenario, blood pressure rises early, but then plateaus and even falls in most people. So there are three components of high blood pressure that really factor into aortic disease. One of them is the blood pressure during exercise. One of them is blood pressure as you're walking around in day-to-day life, which can also vary by a lot of factors. How much exertion do you get on a daily basis? What kind of anxiety or stress is present in your life? And so that is another important component to measure, because it can be different from the blood pressure you measure at rest or in the office. And finally, that vascular stiffness component that I mentioned, which can be very abnormal in people with aneurysms and dissection. So we really have to measure and treat all three components if we want to improve outcomes in our high-risk patients with vascular disease. So this is what we say in our exercise guidelines. I have exercise guidelines that we published in our clinic and we give out to people who are newly diagnosed. You can lift whatever weight you can comfortably lift without having to bear down. So bear down, or the Valsalva maneuver, means that straining feeling you feel in your chest and abdomen when you're lifting something heavy. That in general is the maneuver that tends to drive up blood pressure when you're lifting heavy weights. So if you can lift something without doing that, we know that your blood pressure will stay low based on weightlifting studies that were done in the past. So that's a common rule of thumb that anyone can follow if you do want to lift weights. Daily light to moderate aerobic exercise. Again, that 1 hour per day is really a benchmark, but any amount of exercise, as I showed you, has a dose response curve where you're decreasing your mortality and improving cardiovascular fitness. So that should not be it should not be a yes or no. It should be, I'll do as much as I can. And if I can do an hour, that's great. If I can't, if I don't have time, at least I'm doing something, and that's better than nothing. And what about more intense regimens? So I have patients who've told me they want to compete in a cycling race or run a marathon, and that can be okay. The question is, have you checked all the boxes? So what are the boxes we need to check in those cases? So there are also some other things that we talked about. So if you have a lot of musculoskeletal issues, that can be an impediment to exercise. And so here's some things that I often talk to people about with specific kinds of issues that might impact exercise. Avoid chiropractors for neck and upper back pain. Manipulation has been shown to increase the risk for vertebral artery dissections in some people who have aneurysms of the neck vessels. If you have iliac artery aneurysms or dissections, squatting maneuvers and some forms of repetitive stress, like rowing, can potentially pose a risk. So it's important to understand your anatomy and have a discussion with your doctor before you decide to participate in those types of exercises. And one common thing that's very important to everyone is to avoid straining with bowel movements, because again, that is the same Valsalva maneuver. And so if you do have constipation, make sure you talk to your doctors about getting a stool softener or getting that diagnosed and treated, so you're not putting yourself at risk over a longer period of time. So if we have patients who want to exercise, here are the boxes that we check. We want to do a thorough genetic evaluation to identify a gene mutation if it's present. Look at your family history. Is there dissection in the family history? If so, what were the circumstances of the dissection? Do you have any medical or physical contraindications to exercise? Do you have high blood pressure? What medications are you taking? Do a history and physical to make sure that you are, there are no obvious red flags that need to be looked at before you start an exercise program. Image the aorta. What is the state of your disease? Is your aneurysm enlarging? Do an exercise test. Now, this would be for the case for someone who really wants to pursue a more vigorous exercise program. We want to know if they have that exertional hypertension. We can put them on a treadmill, and it's fairly easy to measure your blood pressure response to vigorous aerobic exercise in a controlled setting. That will tell us a little bit about your risk parameters. How much does your blood pressure increase? Does it stay elevated after you finish exercise? These would be abnormal markers of someone who might be at risk for exertional hypertension. We can do an ambulatory blood pressure monitor. These are 24-hour monitors that record your blood pressure automatically, and we can upload those to a computer and understand how your blood pressure varies with daily activities or stress. And we might need to change your medications. So all of these things can be used to create targeted antihypertensive strategies and also an exercise prescription for people who want to start an exercise program or ramp it up. Here's some other things that we actually measure in doing all that. But the bottom line is we get a lot of data from this, and that's not only helpful for you as an individual, but it can also help us learn about the range of aortic responses to exercise and blood pressure responses in individuals with aortic disease, and that will help the community as a whole. So this is the protocol that we do at UT Houston. We have a questionnaire where we ask about your weekly activity levels, and you fill out a consent form. We have you wear this blood pressure monitor. This can be worn during exercise, but also for 24 hours to give us longer term data on your blood pressure. We measure your blood pressure at rest and during several standard exercises that we chose because they have both aerobic and isometric components. An example would be bicep curls, hand grips, 6-inch leg raises, wall sits, stationary bicycle, and treadmill. And we also measure your blood pressure during recovery to make sure it's coming down appropriately. So the inclusion in our study is anyone who's been diagnosed with an aneurysm or dissection, whether it's been repaired or not. We have some restrictions based on the location of the dissection if it involves the head and neck muscles. Vessels, but other than that, almost anyone can participate. We've excluded very few. The main exclusion criteria would be age less than 18 years, uncontrolled hypertension. If your resting systolic pressure is greater than 160, we would have you get that controlled before you try the study. And if you had a recent injury where we feel like you're not completely recovered, we would ask you to wait until for a little longer until we can reassess you. Or if you're unable to do exercise, obviously that would be a contraindication. But in practice, most people can participate successfully because these are moderate and not strenuous activities that we're doing. So I'd like to give you some updates on the first around 50 people who've done the protocol. We're publishing this result in Frontiers in Sports and Active Living. Hopefully that will come out later this year. So we had about twice as many patients as controls. Only about 10% of people could not complete even one exercise. There were a relatively small number of individuals where we had technical difficulties because their arms were moving primarily. And so we were unable to obtain blood pressure measurements during at least one exercise. But the vast majority of patients were able to complete the exercise and have blood pressure measurements. So technically it was successful. They most often failed during leg races and cycling because that's where people tend to shake the most. And it's very hard for the blood pressure monitor because it's sensitive to vibration. So this was some results. So we did find that more patients, even though they were more likely to be on blood pressure medicine, did have systolic blood pressures with exertion that exceeded 180 millimeters of mercury, which in our study was kind of the cutoff for severe hypertension. So these were the exercises where they occurred most. And again, most of them are going to be isometric exercises. So your wall sits where you're really straining, that will drive up your blood pressure because it's inducing you to do a Valsalva maneuver. This is the Borg scale. So a Borg scale is a measure of effort where 1 is very minimal effort and 10 is the most effort ever. And you can see that a lot of the isometric kind of exercises were the most intense and therefore would be expected to drive up blood pressure the most. We also found, as you might expect, that the amount of weekly activities that our participants reported did correlate with the blood pressure response to exercise. So this is just in patients. And so what you're seeing is the amount of self-reported moderate activity and the systolic blood pressure response greater than 180. So again, 180 was during exercise. Did we measure at least one exercise where they hit 180 millimeters of mercury? And you can see that if you reported more than 1 hour per day of moderate activity, we simply didn't see that for systolic blood pressure. And very few individuals with diastolic blood pressure had a hypertensive response if they participated in more than 1 hour per day of moderate activities. You can see that on top, the moderate activity levels that we reported were all over the place for the group, but most people in the study reported 4 hours or less per week of moderate activities. So this, again, the other thing that we noticed is that the dose response effect on blood pressure was true for systolic blood pressure, but not, was true for systolic blood pressure in bicycling, but not for wall sits or other isometric exercise. So aerobic activities, as I mentioned, had a very predictable increase and plateau in systolic blood pressure, whereas in isometric or isotonic exercises like wall sits, we had these sudden and rapid surges. And it turned out that with training, apparently you can reduce your blood pressure response to aerobic exercise, but not as predictably with isometric exercise. Again, fitting into this pattern where the blood pressure response is just not as predictable. And that again has to do with the variability in the technique when one performs an isometric exercise. It just requires a higher level of training and awareness of breathing, as well as the technique one does when contracting one's muscles. The other thing that we saw was in individuals with thoracic aortic disease, their blood pressure tended to drop abruptly after exercise. Now, this can cause symptoms, and I know some people report that after they exercise, they might have a headache, sometimes blurred vision, sometimes even feeling faint. This is very common in people with thoracic aortic disease, so you're not alone. And the reason for this in many cases is because you're on medications that promote this effect. Being on antihypertensive certainly can do that, but also we found that these individuals tended to have increased vascular stiffness, which is that component I talked about. You can kind of think about the aorta as a capacitor, so it expands when blood goes through it, and it contracts when blood goes out of it. And that kind of helps to maintain blood pressure. But if you have a graft or a dissection, it becomes more like a pipe, and it doesn't expand and contract. Therefore, blood pressure can rise and fall more rapidly. And that's exactly what we tended to be seeing in these cases, and might explain some of the symptoms after exercise. So we also looked at individuals with dissections versus aneurysms, because a lot of you had questions, particularly after an aortic dissection, how safe is it? We did find that dissection survivors had lower exercise diastolic pressures and higher pulse pressures, indicative of increased stiffness, as I mentioned. They also tended to be on more medications, and they had a higher drop in their post-exercise blood pressure. However, there was no significant difference in their ability to complete the exercise or their overall blood pressure response to exercise. So they were able to complete the protocol just as well, and they didn't have any increased rate of adverse events in our, again, small sample size of 50 participants. We also completed a survey of all of our participants, like Carmen, after the exercise study to see how the experience affected them. So half of them said that they were more confident in their ability to complete exercises safely, and 2/3 said they would participate again, which is great news because we'd love to track their performance over time on this protocol. And 3/4 reported getting feedback about their 24-hour blood pressures was also valuable, which can give you a lot more insight than just a few checks per day, which most of us can do in our available time. So in conclusion, people with aortic disease can safely and effectively perform a wide variety of moderate intensity exercises. We found that people with thoracic aortic disease do become more hypertensive during some exercise, even though their resting blood pressure was not significantly different than controls. And this highlights again the importance of getting exertional blood pressure checks as a separate entity from your resting or even ambulatory blood pressure, because the two are not necessarily going to be normal at the same time. And finally, increased water, the more you exercise on a regular basis, the better your systolic blood pressure response can be to aerobic types of exercise, but not necessarily to isometric or isotonic exercise, which tend to be less predictable. So that can inform how we create an exercise prescription for individuals who are in the protocol. So the goals moving forward are to expand the study. We'd love to start a multi-center study. In fact, looking at the opportunities going forward, I'd love to submit a grant proposal to do this as a potential treatment for TAD, where we would assess individuals over time, get them trained up and able to do this protocol on their own, and then monitor their not only their overall well-being and their blood pressure, but also their aortic disease to see if we can really make an impact on the number of people who need procedures in the future or need further treatment. So this would be a home exercise protocol with regular clinic follow-ups where we would again reassess them on the formal protocol and see how they're progressing. And we would also reach out to them with an app that helps to guide their home exercise, which is what I asked about at the beginning. So obviously we're soliciting a lot of volunteers, and I am pleased that so many of you were interested in signing up. I think I'll stop there and answer some questions maybe.
That was wonderful. I think I can speak for everyone and say that we love this info. It was really exciting to hear. I love this new way of thinking about it. Not just, is this dangerous, but how is it helpful? I think that's really important framing. We have only a few minutes left, but I'm sure you're super busy. Do you need to leave us right on the hour, Dr. Prakash?
No, I can stick around. I did look at some of the questions you sent in, and I wanted to maybe start with them, and then if you wouldn't mind helping me with some of the chat questions, so I'm not all over
absolutely.
the place.
I can definitely moderate those for you, but go ahead and start with the ones that I sent you. These were the ones that you all sent in when you registered.
Yes, thank you for doing that. So I got a lot of questions about weightlifting, and hopefully I answered some of them in my talk, but to summarize, there is no one weight limit that is appropriate for everyone. You know, a 100-pound woman should have a different weight limit than a 250-pound man. It never made sense to me, and our data totally does not support that, right? So your blood pressure can increase dramatically, even lifting small weights. There's no rule of thumb here. As I mentioned, it's unpredictable in terms of weightlifting. My advice, of course, is to avoid straining and avoid high repetitions. So if you're going to lift weights, you start with a small amount where you're definitely not straining, and you gradually increase so that you train your muscles and you don't fatigue yourself. Because if you are fatiguing or struggling to lift that weight, your blood pressure is definitely high. So you should not do that. The goal of this should really be for toning, for endurance, rather than really muscular buildup, because that sort of powerlifting can definitely impose a great stress on your blood vessels. And so what we want to emphasize is practical things that people can self-monitor and be able to adjust on their own as much as possible, because we know that it's very difficult to get constant advice about this. Let's see. So can I use my Apple Watch? I get a lot of questions about this because so many people have activity monitors or watches, and they want to know, can I use it while I'm exercising to somehow stay safe? The answer is maybe. If you get one of these exercise protocols where we observe you and we know what your heart rate is, for instance, on aerobic exercise, when your blood pressure is reading high, we could come up with common sense heart rate restrictions based on what your blood pressure did on the treadmill, for instance. But just doing it without that data, it's very difficult because the relationship between your heart rate and your blood pressure is changed by the medications we're all on, right? For aortic disease, like a beta blocker is going to slow your heart rate when you're at a higher level of exertion. So you can't go by what would be true or what's published for someone else. Because everyone, like I said, is unique. And so you really need to have that example data, and then we can put that in our exercise prescription for you. Let's see, is Pilates a recognized way of exercising? Yes, Pilates and yoga, I had a few questions about those, are highly desirable ways to exercise because they're low impact, and in many cases, they can promote tremendous flexibility as well and address a lot of the musculoskeletal issues that our individuals with aortic disease tend to have. There is no comparable data on safety yet for Pilates and yoga that I'm aware of compared to things like cardiac rehab, but it's certainly something that we would love to incorporate into our protocol, because I think it's really of vital interest. And questions like this just make me more determined to do that going forward. Let's see. I think I'll stop there and ask Ellen if there are any questions in the chat that we should
Sure.
highlight.
I'm gonna see if I can show them for everyone as I talk about them to see. I haven't used this feature yet. So we've got a quick one here. I think we can all see this now. Just to confirm, rowing machines are not ideal.
Okay, so ideal is kind of a loaded word. So, I mean, there is no absolute limitation on what people can do with, with aortic exercise. It's very difficult to say on a general basis. The reason why rowing got rated as a strenuous activity is because it tends to promote both translational stress on the legs and arms and a lot of aerobic stress. So it's classified as a very high dynamic and static exercise. That's why it's generally not ideal for people with aortic disease. If you rowed all your life and you were in great shape and you could row effortlessly, then theoretically it would be fine. But I know that the vast majority of us really labor to do that kind of exercise. And again, fatigue is what you want to avoid here. So I would say that it's less likely that you could do it without fatigue.
Okay. All right, this one. A few people are asking, how do they volunteer?
You can contact me. I guess we can put it in the chat, I guess, how to contact me. Email is the easiest, and we can set you up. I have a research assistant who is scheduling folks when they come down. Though I can describe the protocol briefly. So you need to have at least a couple hours with us in order to do the actual exercise protocol. And if possible, we would like you to wear the ambulatory blood pressure monitor longer, so either before or after the exercise. So if you're coming from out of town, for instance, having a night where you can wear it, followed by the exercise, either one way or the other. So over the course of a 24 hours would be the best way for us to get all the data we need to help you out. Obviously, we do a lot with just the exercise component, and that's fine too.
I think Bella is here, who's a research nurse who works with the John Ritter Research Program. So maybe she can add that contact info to the chat on how to get in touch about volunteering. Okay, we have one question, then a similar one about can their cardiologists give this assessment as well? Just the regular cardiologist they see, or do you have to see someone specific?
Right. So it depends on the kind of exercise you want to do. So if you're looking at aerobic exercise, a treadmill test, which I've often prescribed for my patients, can be done in most cardiology offices and is a good marker for the kind of blood pressure response that we're looking for during aerobic exercise. If you have questions about isometric or isotonic exercises, those are more nuanced and really less predictable. And so we really need to observe you doing them, because training is important. So if we observe you breathing, we can sometimes make suggestions based on how to breathe during those exercises to minimize blood pressure changes, for instance. It's very difficult to get that from a regular trainer or cardiologist. And so that's more like a specialty question that we can address if you come to visit us.
We have one, I'm not going to put it just because they put some personal details in here, but they're asking about your diastolic blood pressure, because we heard you talk a lot about the other type. And here she is saying that the diastolic is always high despite being on blood pressure medications. So does that increased risk? Maybe you can just comment about those two different numbers and which one is which, maybe, just so we're all on the same page.
Right. So almost all the studies with aortic disease have talked about the top number, which you've heard a lot about, systolic blood pressure. There's also a bottom number. And there haven't been a lot of studies, unfortunately, on the outcomes related to diastolic blood pressure. I think that's a great question. In people without aortic disease, however, we know that diastolic blood pressure has an equal weight in terms of your long-term risk of dying from heart disease. So in other words, the diastolic number should not be ignored. It is very important. And a number above 80 is abnormal, and it should be treated just the same way you would treat a high systolic number. So we look at both of them. So really you want to be less than 130 over 80. And if your diastolic is 90 or above, it definitely requires medical treatment to get it down. And sometimes the types of medicines that are good for diastolic pressure are different from those that are good for systolic. So that's the other thing to consider. You may be effectively controlling your systolic, and you need to be on another medication for diastolic.
That's really interesting.
That's something that we can look at.
I don't have it in front of me, but I saw someone else ask about different types of blood pressure medication, mentioning that they had bad side effects from a few. Can you quickly mention the major classes of medication, and maybe if there's one that, so they asked, what's the one with the least side effects, which I'm sure is different person to person, and I'm sure we'd all like one with absolutely no side effects, but it sounds like they've had a tough time finding one that worked correctly for them without side effects.
Yes. So the major classes of blood pressure medication with relevance to aortic disease are beta blockers. That would be things that end in olol, like metoprolol, atenolol, carvedilol. And then the other one would be angiotensin receptor blockers, and those are like losartan, irbesartan, valsartan. So many of you would be on one or both of those medications, and they have very different side effects. So the main side effect of the angiotensin receptor blockers is changes in your blood minerals, like changes in your kidney function or your potassium level. So those require you to get your blood checked every 6 months or a year, depending on if your kidney function is abnormal, which may be more, in which case you may be more likely to develop those side effects. Most of the time, they don't cause other issues except related to possibly having blood pressure that's too low, like being dizzy. Now, beta blockers are a different story. Beta blockers work by slowing your metabolism. They slow your heart rate and everything. And so fatigue, like Carmen mentioned, is the main side effect. And people often feel like, especially when they're starting, that they just don't want to get out of bed. And they can also, because of that, increase weight. So weight gain is very common. If you have diabetes, you may be more likely to have higher blood sugar on beta blockers. So they're definitely not for everyone. Before you have a beta blocker, you need to have an electrocardiogram to make sure you don't have an abnormal heart rhythm. Some people have heart rates that are just too slow, even without beta blockers. And then, of course, if you do get those side effects, make sure you let your doctor know. There are often surprising improvements if you simply change the type of beta blocker you're on. And fortunately, we have a lot of choices. There are more than half a dozen different types of beta blockers. So if you're stuck on one and you're not feeling great, ask your doctor if you can try a different one. And we know that most of them are highly effective in terms of blood pressure response and doing the same things for your heart and blood vessels. So I would encourage you to look around and see if there are alternatives that work for you.
That's a great answer. Okay, this person says, I'm worried because I don't want my blood pressure to go too high. What are signs or symptoms you should look out for when exercising that might suggest it's too strenuous? I think you mentioned a few of these, like feeling like you're bearing down, the Valsalva maneuver. Anything else? I know for low blood pressure, you mentioned after exercise, feeling dizzy or lightheaded, but are there physical signs of the reverse, that you're going too hard?
Yes, so a physical sign to look out for is where you feel exhaustion. You should not exercise to the point where you feel like you can't continue for another rep or another minute. That's too much. You need to stop before you reach that point, because once you get exhausted, your blood pressure will shoot up. Your body's under stress. It's telling you it's time to quit. I don't want to be out here, and it will lead to distress signals that are frankly quite harmful. So what we try to do is let people know your limits and try to stop well short of them. It's okay. You can gradually increase the amount you do over time. But if you push yourself too hard, it has detrimental effects. And there are recent studies showing that people who do vigorous exercise actually have worse outcomes over time. That there is an upper limit to what you can do on a regular basis that is healthful. It's kind of a U-shaped curve where you get beyond that, you can actually cause health problems related to overexertion. So the important thing is to start slow, gradually ramp up what you're doing, and not reach that critical threshold where you're exhausted.
Okay, this is another one where they put some personal details in, so I'll just summarize it. They have a different blood pressure. It sounds like they've had a complicated dissection that required some bypass of different arteries, so they have different blood pressure on different sides of their body. And can this complicate the story about keeping your blood pressure low? Should you just err on the side of whichever's higher and say that's your limit side, or is this just something that is individual, and he or she needs to speak to someone individually?
Right. So this sounds like a very individualized type of answer, but in general, if you have a dissection that blocks blood flow on one side, you should not be checking your blood pressure on that side. You should check it on the non-block side. And if you're not sure which side that is, talk to your doctor. That's
Okay.
what I would say, without knowing more
Sure.
about the case.
Okay, we have one that's slightly, I know this is actually within your wheelhouse, so I'm going to put you on the spot about it. Sleep apnea.
Great
risk of
question.
dissection.
Yeah. So one of the things that I look at when we do our 24-hour blood pressure monitors is the risk for sleep apnea. So we can actually detect sleep apnea fairly sensitively with 24-hour blood pressure. And the reason why is that normally blood pressure drops profoundly during sleep because your body relaxes. But in people with sleep apnea that is significant enough to block airflow, their blood pressure abnormally rises during sleep. And it's a very sensitive marker that can often be the first sign of a problem. So even if you're not aware of it, your blood pressure will tell the story and we can get you tested and treated. Sleep apnea is much more common in people with thoracic aortic disease. For some reasons we recognize and some we don't. An example of reasons that would cause that are in some people with genetic mutations that affect the head and neck, the bones in the head and neck. They can have abnormal airflow because of blockage due to that. Other people may be obese or have high blood pressure, or even the medications that you're on can all contribute to the risk for blockage. So it is common. I do recommend that anyone who has any risk factors for it, or a family history, or even someone has told you you have loud snoring, get checked for sleep apnea because it is totally treatable. And it can also reduce your risk for both high blood pressure and aortic dissection. There are some studies that show that individuals with type B dissections who had sleep apnea did tend to dissect more at night in the early morning hours. And the implication is that the sleep apnea was driving up blood pressure and causing the dissection. We don't have actual data to confirm that, but it is an association that is present.
That's so interesting. And I know a common, my sister has it. It's a incredibly common condition. So I'm sure there are a lot of people out there who have some in their family too, if not themselves. So someone's asking about the different segments of the aorta. So when we think about maybe the root closer to the heart versus someone who might have a type B dissection in the descending, or an aneurysm in the arch or elsewhere, does that matter in terms of what's worst affected by blood pressure? Are we most worried about that segment that's closer to our heart and maybe less further, or it's not? It's all bad. Yes. For it.
So different segments of the aorta are affected differently. As I mentioned, the beginning part of the aorta is really the part that expands with each heartbeat and contracts out, when the pulse goes past it. So that changes the most in shape during each heartbeat. And that is the one that is most strongly affected by blood pressure. However, any part of the aorta that is weakened, either has an aneurysm or dissection, will be more vulnerable to changes in blood pressure and therefore needs to be protected. And that can include the descending aorta or the abdominal aorta. So that's why I said that assessment of disease is so important, because you can have different effects of blood pressure on different parts. And unless you know how those are changing, you won't be able to either, to feel confident in scaling up your activities. Regular assessment is critical.
Is it possible to buy something to monitor your blood pressure during activity for your home use, or working out at your own gym or on your own?
That's a great question. So with the rise of wearable technology, there are lots of companies that are offering blood pressure monitors. Unfortunately, none of them are very good yet. That might be changing. This is one of those wait and see things. The problem is that a lot of the early ones were wrist-based. So there were wrist cuffs that were designed to be convenient, but those don't work very well at all, particularly for people with aortic disease. They're not accurate. They can tend to underreport blood pressure, which has the sense of giving you a false sense of security. because you might think your blood pressure is normal when it's not. We recommend arm cuffs, and there are some arm cuff home units that are okay for measuring at rest blood pressure. But the problem is none of them are really validated for the kind of measurements you would need to do while you're exercising. So that's why we tend to do them in a controlled setting where we are actually physically monitoring you and holding your arms still so we can get a proper reading because it takes some experience even for us to do that. I wouldn't recommend it to anyone who doesn't have the right equipment. And even so, it can be very tricky to get reliable readings. So at this time, I would say no. There's nothing reliable that I would hang my hat on, and make my decisions on.
Maybe we have some entrepreneurial engineer out there who can create such a product for our community.
That's right, exactly.
Okay, this in regards to testing pre-exercise, I thought this was interesting. Are stress tests done to exhaustion safe to do?
Right. So the typical way we would do a stress test on an individual without aortic disease is something called the Bruce protocol, which means you keep going until you wave the white flag and they get out and they stop the machine. That is, of course, pretty risky if you have high blood pressure, because sometimes that, as we mentioned, that's what you want to avoid doing. So we do something called the modified Bruce, which is a lower intensity form of the Bruce where it doesn't go to exhaustion. That's what I would order for someone who wanted to do that. And there's a protocol. Most cardiology offices know what that is, and they can throttle it back accordingly. But if there are any questions, I always tell them to just call us, and we can tell them what to do.
This is related enough, I'm going to ask. Caffeine raising our blood pressure. I think a lot of people, I've heard anecdotally from a lot of people, oh, I'm sure it was my energy drinks that gave me an aneurysm, or I'm sure it was the 10 cups of coffee I had a day. So this is something good to address, I think, for everyone.
Yes, so there is some data about caffeine and blood pressure more recently that shows that regular consumption of caffeine has minimal or no effect on blood pressure and may actually lower blood pressure. Whereas infrequent consumption, people who drink less than 1 cup per day, who suddenly have 3 or more cups, will experience a transient increase in blood pressure. So the advice for coffee drinking is, yes, you can do it, but do it in moderation and do it consistently. If you do those two things, you're unlikely to experience a significant change in blood pressure in response to caffeine intake.
Okay. Someone was talking about going on special diets prescribed due to their high blood pressure. I know you're not a registered dietitian, but obviously you have a lot of experience with this. Can you comment about how diet affects our blood pressure? I know you mentioned it a little bit in your presentation.
Yes, so sodium or salt intake in your food is the main determinant of how your food affects your blood pressure. So in general, to lower blood pressure, or if you have high blood pressure, you'll be prescribed a low salt diet. The one that is very popular and has been shown to be effective for people with hypertension is called the DASH diet. You can Google it, DASH. It was part of an NIH study where they randomized people to that diet and they looked at their blood pressure. And on average, it lowered blood pressure by the top number by about 12 millimeters of mercury. Just their dietary change, because it involves lower salt. So my advice to everyone is you can make major changes with diet alone, but it needs to be sustained. And I find that the DASH diet is more, preferable to a lot of patients to be on for a lifelong, rather than something that they might only be able to maintain for a few months. Something
like really restrictive, which maybe you aspirationally start and then 1-2 months later, it's all gone and you're back to the start. Right. Okay, I think we're getting to the end of these things here. Someone asked about core exercise and said it seems like most of these are going to be not allowed because a lot of core, planks, holding a V shape, all these things. Is there anything, I know you're not an exercise trainer, but they're asking what's safe to do that's a core exercise, which I think is important for things like stability.
So we did test a few core exercises because of patient demand. We started out with planks, but we just weren't able to get accurate enough blood pressures during planks because people were shaking too much. So then we switched it around to leg raises, and that seems to work really well. And actually, most people can do it without a significant increase in their blood pressure. So it's a 6-inch leg raise where you just lie on the floor and you stick both legs up and hold them for as long as you can. we are able, we typically get measurements over a period of 2 minutes. So that could kind of give you an indication. And only a handful of patients were unable to complete that in our protocol. We also found that the blood pressure response was much more reasonable than, say, something like a wall sit. So that's certainly something that we would encourage if you wanted to do core. We did not test it, of course, with weights on the ankles or anything like that. This was just body weight. So again, it would depend on the level of effort. What we found is that if people are really fatiguing and again, they're shaking and you're straining, that means it's probably too much for you and you should back off. But if you're able to do it comfortably and hold that, it seems like it would be a viable option.
Okay, I think we're down to 2, so appreciate you giving us extra time here. One is about people who are at risk because they have a known genetic condition, but they might not have a dissection yet, or they don't have an aneurysm yet. Do they need to be, acting as if they are affected? Is that the safest thing to do? Or would you say for someone like that, if you know that if you've been imaged, you have normal size aorta, live normally? What would your advice be to someone in that space?
So if your aorta and all your blood vessels are normal and you don't have hypertension at baseline, what I would say that you can live your life normally, but if you wanted to exercise vigorously, it would be a good idea to get checked out just to make sure you don't have exertional hypertension in that setting. But on a day-to-day basis, I don't think it should affect how you live your life.
Actually, I'm sure I'm probably missing someone, so I apologize, but I think that's pretty much it, unless Meredith wants to ping me with something major that I missed in the chat here. There's a lot going back and forth, but hopefully you all really learned a lot and feel like you are more confident going forward as you begin your activity journey. Please let us know your thoughts about today's presentation. You can always reach out to us. And I think Bella put the info for joining Dr. Prakash's study in the chat. But thanks for attending, and mostly thank you to Dr. Prakash again for joining and sharing your wisdom. This was highly requested by our community, so I appreciate your time today.
Thank you so much, Ellen, and thanks to everyone who tuned in. Good luck with your with exercising, and have a safe and healthy summer.
Yes, absolutely. You too. Thank you, everyone. Enjoy. Have a great weekend.
Bye.